this session. I am going to chair the session with my colleague, Dr. CANPOLAT Ayhan. And for at least 10 years, we have been talking about hemophilia gene therapy. And we are all excited about hemophilia gene therapy because the appeal of hemophilia gene therapies is that they are single dose treatment that corrects the factor deficiency rather than continuous replacement of it. However, there are still questions in our minds. The first question is about durability. They are potentially curative, but whether they will really offer a cure depends on how long their effects last. And the second important question, who is the right candidate? Because there is still uncertainty about which patients are likely to derive the most benefit from this approach. And ongoing trials are enrolling patients without inhibitor and anti-AAV antibodies. In this section, we will hear about opportunities and threats in gene therapy to hemophilia from Mr. O'Mahony, former president of World Federation of Hemophilia. He is currently the chief executive of the Irish Hemophilia Society. He is the vice chair of the Hemophilia Product Selection and Monitoring Advisory Board. He communicates with various stakeholders to prepare policies for the benefit of hemophiliacs.
First of all, I want to thank the organization. First of all, I want to thank the organization committee Dr. Bülent Zülfikar and Dr. Kaan Kavaklı and other colleagues. And I want to say that it's a great pleasure for us to share this meeting with Brian O'Mahony. And I want to introduce him to make his speech.
Mr. Mahoney, please go ahead.
Thank you very much. It's a great pleasure to be attending your meeting. I just wish I was able to be there in person on this occasion. So I want to talk about gene therapy for hemophilia, and rather than opportunities and threats, I've called it opportunities and challenges because I think there are challenges rather than threats. So currently there are many hemophilia gene therapy trials underway, but highlighted here are the 3 factor VIII gene therapy trials which are currently in phase 3 from BioMarin, Sangamo, Pfizer, and Spark Roche. And there are also 2 phase 3 factor IX clinical trials from Pfizer Spark and from Unicure. And there is, of course, a lot of unmet need in hemophilia. Despite the great advances in treatment in the last 10, 15 years, there are many unmet needs, including joint damage, poor health-related quality of life, functional impairment, social isolation, pain, both acute and chronic, psychological impact, and personal productivity. And of course, not every individual has all of these unmet needs, but all of these unmet needs can be found in the community. You also have the intrusiveness of chronic therapies, the requirement when you're taking treatment to be aware of peaks and troughs and to manage your activities around those peaks and troughs. The problems of joint morbidity and physical challenges. Also the mental health impact, including anxiety and depression, which is reasonably prevalent in hemophilia. Then there's the disability paradox, where it has been seen clearly that people with hemophilia overestimate their health-related quality of life compared to the general population. And that overestimation, a figure has now been put on that of about 17%. There can also be a loss of work productivity and social inclusion. When you're looking at gene therapy and looking at therapies as a person with hemophilia, I think the decision drivers for you will be relating to your experience of living with hemophilia. So for any individual, you will look at his annual bleed rate and his bleeding phenotype. What kind of state of his joints in? Does he have target joints? What is his current level of activity? And what are the barriers to increasing that activity? Whether or not he has needle phobia or poor venous access. And also there can be a fatigue of living with severe hemophilia. And I remember one individual saying that he wanted to try gene therapy because he wanted to experience life without severe hemophilia. And also, of course, it depends on the access to current therapeutic options in your country. So the extent to which gene therapy may be attractive to an individual, to a country, will depend also on how good their current therapy is in the country and what therapeutic options they have available. In terms of the opportunities that gene therapy presents, well, it presents the opportunity for a functional cure. I think in the last year or two, we've moved away from talking about gene therapy as a cure per se, but perhaps as a functional cure, perhaps for a period of time. Freedom from regular intravenous or subcutaneous injections, a decrease in chronic pain, a decrease in impairment in the activities of daily living, and an increased activity to participate in normal activities in sports. Now, I'm not talking about extreme sports, but I'm talking about walking, running, cycling, playing soccer, normal activities in sports that most people take for granted. And freedom from the mental burden of planning life around hemophilia, or what some people have called the freedom to be spontaneous in life. And also freedom for individuals to travel or to work abroad, because currently it is difficult to move to another country if you have severe hemophilia. There are restrictions. Gene therapy may change that. And it can give you, this is a recent publication by Cedric Harmons and colleagues, where they talked about a hemophilia-free mind. Now, I'm not sure your mind would be free of hemophilia, but I think it would free up an amount of space that you use in your brain for dealing with hemophilia on a daily and regular basis. And if you look at the outcomes that we want from gene therapy, and a group of over 50 individuals, including payers, HTA experts, companies, clinicians, and patient leaders got together, and we defined the 6 outcomes that we want to see from gene therapy: factor expression, duration of expression, chronic pain, mental health impact, annual bleed rate, and resource use or cost. And the reason I have factor expression highlighted is because the regulators would often look at annual bleed rate as the most important outcome. But in fact, for those of us who looked at this carefully, we reached a consensus, and that's the paper on the right-hand side, that factor expression was the most important. Everything else really flows from the factor expression that you achieve. Having said that, in a recent discrete choice experiment in people with hemophilia in the USA, they felt that the most important outcomes for them of gene therapy would be the decrease in the annual bleed rate and the decrease in the treatment burden, or the regularity of having to take intravenous injections. So the challenges that we have with gene therapy, what I call the abilities: eligibility, durability, variability, reliability, affordability, and safety. If you look at eligibility, there are a significant proportion of the community who are not eligible for gene therapy. Currently, you cannot give gene therapy to a child under the age of 18. Those who have pre-existing AAV antibodies to the vector being used cannot be treated, with the exception of the Unicure AMT-061 factor 9 trial, where they are able to treat people with pre-existing antibodies. Those with inhibitors or a history of inhibitors, those with unresolved hepatitis C, HIV is also an inclusion in some clinical trials, and it remains to be seen if there will be an upper age limit for adults. Now, when gene therapy is licensed, it's probable that in most jurisdictions, the licensing will follow the same restrictions as the eligibility for the clinical trials. But it depends. I'm not sure there's a real rationale for excluding people with HIV, and I don't know if there will be an upper age limit for adults. So if you look at the numbers in Europe, and I did an exercise where I looked at all of the numbers of people with hemophilia reported to the WHO Global Survey for 18 European countries. And in those countries, 44% of those with severe factor 8 or 48% of those with severe factor 9 would be theoretically eligible for gene therapy. So if you took it that 25% of those who are eligible would be treated with gene therapy in the first 5 to 10 years, that's probably 11% of the total severes and 12% of the total factor 9 severes. In terms of durability, it's looking likely that factor 9 gene therapy may be durable for at least 10 years and maybe longer. And this is based on the data from the UCL trial in the UK with Natwani and Tottenham's work, and also with the 4-year data from the AMT-060 factor 9 trial, where we're seeing a durable expression of factor 9 for at least 4 years or at least 10 years in the first instance. With factor VIII, it appears that the factor VIII expression decreases with time, but according to David Lillicrap and other people, it may be durable for at least 5 years at a factor VIII level of at least 5%. And I think we can certainly say that for the moment, and it may be longer. So for factor IX, you're looking at probably 10 years at least, and factor VIII, probably at least 5 years and possibly more. In terms of variability, there was a high degree of variability with all the gene therapy trials, ranging from no expression to super physiological levels. And so the mean and median are not the entire story. When you look at the gene therapy factor expression graphs, you have to look at the box and whisker plots. You have to look at the very wide range in terms of the variation of expression. And there are no predictors for which person with hemophilia will achieve a particular expression. And there's a greater degree of variability with factor VIII, up to a 10-fold variability, and less variability with factor IX. And this is the valoctocogene roxaver-pavlovac biomarron phase 3 1-year data on 134 people with hemophilia. And you can see here that the expression, you can see that the mean was 42.9% and the median was 23.9%. And if you look at a smaller cohort of 17 treated over a 2-year period, you can see that by year 2, the mean was 24.4% and the median was 14.7%. But you can see from the box and whisker plots here, there's a very wide degree of variability, ranging from no expression up to, in some cases, up to almost 250%. In terms of reliability, we know that a small proportion of people with hemophilia will not respond to gene therapy. They'll get no expression, or get a very low factor expression. And that may be up to 10% of people who do not respond or who get expression below 5%. And again, there are no predictors of who may not respond. And of course, you can't redose. And some non-response may be due to a reaction at the time of infusion, leading to cessation or incomplete dose infused. And we've seen that certainly in some of the trials, where the small proportion of people will get a reaction at the time of infusion. And in one of the factor IX trials, at least one individual did not get a complete dose, so they got a suboptimal expression of factor. So there is uncertainty about the proportion of people who will not get a good expression. In terms of safety, well, there are short-term and long-term safety concerns. In short-term, transaminitis is quite common due to inflammation of the liver because of the introduction of the vector. And this can lead to loss of factor expression and therefore may require the use of steroids to save the factor expression. And indeed, the use of steroids in themselves can then have side effects if there's prolonged steroid use required. In terms of long-term safety impact, well, there is a theoretical risk of insertion mutagenesis due to integration. We do know that some integration of the vector does occur, and there has been one reported case of hepatocellular carcinoma in a factor IX clinical trial. With other long-term safety impacts, we've seen in other AAV gene therapy trials, recently reported at an FDA meeting, that with the gene therapy for ALS, a Lou Gehrig's disease, they saw neurotoxicity in the dorsal root ganglion. And with spinal muscular atrophy, they saw thrombotic microangiopathy. But these have not to date been seen in hemophilia gene therapy clinical trials. And in terms of that one case of hepatocellular carcinoma in the factor IX trial, an investigation was carried out. There was some integration, but the conclusion was that the gene therapy as the cause was highly unlikely, that the patient had several genetic mutations that were characteristic of hepatocellular carcinoma, independent of vector integration. In terms of safety, though, we do need ongoing monitoring of liver health. And it's interesting in the last year that more and more of the gene therapy meetings, you are seeing hepatologists speaking. So we do need to have ongoing monitoring of liver health. And indeed, a person with hemophilia, when they're treated with gene therapy, needs to, if the hemophilia is functionally cured for a period of time, they need to develop hepatophilia. They need to start looking after their liver. And the fact is that globally, we will not appreciate any rare adverse events unless we have a global registry. And such a global registry is being developed by the World Federation of Hemophilia. In terms of affordability, a one-off payment model may not be affordable for many countries, because even if it was seen as cost-effective by a HTA body, it would potentially have a very high budget impact. and that would mean that it would not be reimbursed or would be made available to very few people with hemophilia in the country. And you can see here on the right that at one stage, the CEO of BioMarin suggested a price in the range of $2 to $3 million in the USA. But these very high one-off costs predicted in the USA would not be sustainable in Europe or in other regions or countries. And the US probable cost has to be viewed in the context of what they're currently paying for factor concentrates or for emicizumab. And this is from the recent ICER report in the USA, where they looked at comparative cost effectiveness of gene therapy, emicizumab, and both standard and extended half-life factor concentrate. And this was predicted on a cost of $2.5 million, a one-off cost for gene therapy. And that was seen as cost-effective in the States. And that is the case, but that has to be put in the context. Their annual quoted cost of factor concentrate was $542,000 to $858,000 per patient per year. And for emicizumab, $569,000 per patient per year. And it would be very interesting to apply this model, plug in European numbers or numbers for different countries. And I think then the comparison would look very different. And I think there are many alternative payment models. So we must use imagination and flexibility in terms of looking at gene therapy payment models. I believe there are fundamental disadvantages to a one-off payment model. As I said, a huge budget impact and would not be affordable for many countries. But there are several outcome-based payment models and several finance-based payment models, which will be set out in a forthcoming paper in hemophilia. I think a realistic payment model for many countries would be an outcome-based annual payment model, where you would agree to make a specific payment every year for an agreed number of years based on the continued duration of expression and based on a range of expression levels. So, for example, it might be agreed you'd pay this amount for 7 years, 10 years, based on a factor expression between 30 and 50%. And if the factor expression fell below that, then the payment fell. And also, you'd also link it perhaps to a decrease in the use of factor concentrate in novel therapy. And that's something that payers will want to see. That's the cost offset. So on the one hand, you look at the factor expression, and on the other hand, you look at the decrease in the therapy you were using prior to gene therapy as the cost offset. And I think a realistic annual payment amount will be based on the current annual cost of prophylaxis in the country. I think such a system would be potentially attractive to payers because there's an element of risk sharing, because in the small number of cases where you don't get expression, you don't pay, or if you get decreasing expression rapidly, the payment falls. It would be acceptable to clinicians and I believe to people with hemophilia, because then the outcome measures in terms of your factor level, in terms of your CFC or novel therapy use are easily measured and easily adjudicated under a contract situation. But of course, you'd have to evaluate each payment model for each country. And I think this is some work we've been doing in Ireland, looking at the different payment models. So if you look on the right-hand side, if you look at factor consumption, factor expression, annual bleeding rate, annual joint bleeding rate, joint health, generic quality of life tools or disease-specific tools, you'll see that when you look at measures that are meaningful, accessible, timely, measurable, robust and predictable, CFC consumption and factor expression win out. They're the ones that are easier to measure and actually are most useful. And gene therapy is not just another therapy. It's not just another development in the firmament of therapeutic options that we have, but it's a one-off treatment and there's currently no possibility of retreatment. And if you get a poor outcome, however, it does not prevent you from going back to factor concentrates or novel therapies. But it is an irreversible therapy and an irreversible decision. It's the first hemophilia therapy which is irreversible. So therefore, it requires detailed informed consent because you want to avoid treatment remorse. You do not want a person with hemophilia coming back to the clinician afterwards and saying, I wish you hadn't persuaded me to take this therapy. And that requires appropriate patient education and also an appropriate delivery model, which I believe to be the hub and spoke model. And Dr. Miesbach yesterday spoke about the hub and spoke model. This is the agreed model between the EHAD and the EHC in Europe. And so you would have the expertise in supervising centres. And it's the case that not every comprehensive care centre or indeed every hemophilia treatment centre will have the expertise and the detailed knowledge to provide informed consent and follow-up. These are also high-cost therapies. I believe that the payers in many countries will want to control the centres, that these are dispensed or prescribed by. So I think that the payers in many countries would say, look, you have to have a limited number of centres prescribing these high-cost medications. And then the local centres can support and can also ensure equitable national access so that it's not just patients who regularly attend one centre will be getting the treatment, that there's a fair distribution of the possibility of getting gene therapy. In terms of patient education, this must be both comprehensive and comprehensible. So it must be detailed, but also must be understandable for the individual. And you also have to target the education at different demographics and different levels of knowledge of interest. You can use papers, scientific papers, publications, booklets, but also, and increasingly with the younger cohorts, videos, podcasts, infographics, and social media content, as well as telephone apps. And the objective will be to inform and educate the people with haemophilia and prepare them for the point where they're ready for engagement with their centres and with their clinicians to discuss informed consent. So you really want the person with haemophilia to be going in to discuss this with the doctor in a situation where they already have a degree of knowledge about gene therapy. These are some of the educational tools which are out there, but there are also apps, videos, infographics, and many other tools now currently being developed by many organizations. In terms of informed consent, well, I think we talk now in haemophilia about shared decision-making. And first of all, I believe that the patient organizations have a strong role to play in getting the people with haemophilia ready for the point where they're ready to engage with their clinician in an informed consent process. And in Ireland, certainly we do this by having group meetings. So when we've discussed participation in gene therapy clinical trials, we'll bring together 20 or 30 people with haemophilia, with the clinical trial specialist, with the hematologists, have a group discussion. And in that sense, in that group dynamic, lots of people get questions answered that they wouldn't have thought of otherwise. So informed consent for gene therapy should be individualized, should be multi-stage, it's not a single visit, and should be based on the knowledge, the education, and the availability of educational resources to the person with haemophilia. So this individualized approach has to be tailored. It's not just a question of giving a lengthy consent form and asking the person to read that and sign it off. You need to check their understanding. You need to use clear language and concepts. And again, there are many efforts at the moment looking at the development of educational tools and slide decks which can help with this. You need to verify their expectations and match their goals with reality. And this is really important to make sure that they have an expectation going in that's realistic, and also that they're prepared for different outcomes. There should be an opportunity to include their partner or family member or advocate in those meetings. And they must have a clear understanding of the monitoring and the follow-up that's required. So it's not just a question of getting one injection and then you can disappear off into the sunset. There's a significant amount of monitoring and follow-up required in clinical trials, and there will be a significant amount of monitoring and follow-up required when there are licensed gene therapies. Indeed, you would expect to see lifelong follow-up. There are other issues which would have to be discussed, including the potential need for steroid use, refraining from alcohol use, the impact of vector shedding, perhaps on a younger man who might want to start a family. But you also have to scenario test the person's understanding against possible outcomes. So in other words, they might have an expectation of the outcome they'd want to get. But I think you need to check 3 or 4 different scenarios at least and say, what happens if this is the expression you get, if this is durability you get, are you comfortable with that? So really this needs to be properly road tested before a person takes gene therapy. And this is a decision model that's being worked on at the moment. So again, going through different scenarios and deciding on it. I'm getting a lot of feedback there. So my conclusions. Well, I think there's been a remarkable progress in the last 10 years. And the slide on the right-hand side is a slide I used at the UK meeting in 2006. And at that stage, we felt that gene therapy, if it did become available, would be an annual treatment. Now we've moved way beyond that. So we've made remarkable progress in the last 10 years. Licensed gene therapies are highly probable in the next 1 to 2 years. In fact, it's highly likely we'll see the first licensed gene therapy next year. There are many challenges to work through, but I think now is the time for the clinician community and the patient organization community to start engaging with the gene therapy companies, with the regulators, and with the payers, because for example, in areas like new payment models, there may currently not be mechanisms in existence to allow your country to make an annual payment for a one-off treatment. So these mechanisms need to be developed. A lot of this work needs to be done before the gene therapies are licensed. We need to be prepared. And if we fail to prepare, then we can prepare to fail. Thank you very much.
Dear Brian O'Mahony, thank you very much for this excellent and informative speech. I think we have time to take a few questions.
Brian, thank you. Kabaklı speaking. Thanks for your nice and detailed explanations. Next year in Turkey, many phase 3 hemophilia A and B projects will be available for Turkish patients. What is your general recommendation for Turkish patients in respect of to be or not to be, as an expert person in this area?
I think it has to be a very individual decision. I think each person needs to look at their own lived experience with hemophilia, and they need to decide if they want to try a gene therapy as a clinical trial. And of course, they need to be aware of the monitoring and follow-up that's required. And they need to be aware of the fact that this is an irreversible one-off decision. Now, I think what we found very useful in Ireland was, rather than each individual patient just having a discussion with the clinician, as I said, if you can bring them together in a group beforehand. So I would recommend getting everybody who's even potentially interested in gene therapy clinical trial, getting them in a room, having a discussion, going through what the trial is, what the gene therapy is, how it works, what the procedure is, what the protocol is, and then allowing them to ask questions, and then go away and think about it, and then come back, and then at that point to engage individually with the clinician. It needs to be a very considered decision.
Thank you. Because some patients ask if I should wait before approval or I should attend after approval by FDA. So what is your opinion? Is it important to approval by FDA for going to a hemophilia phase gene therapy project, or should we wait after FDA approval?
Well, I mean, FDA and EMA approval are absolutely vital. And if the FDA and EMA approve the gene therapies, then you know you've got a licensed gene therapy, which in the view of the regulators is safe and effective. So that gives you definitely increased assurance. On the other hand, there's no guarantee that your country will pay for gene therapy or that it will be available. So if somebody has an opportunity to go into a gene therapy clinical trial, it does give you the opportunity to access gene therapy without any cost. And I think if you look at it, that there are probably just over 200 people with hemophilia who have taken part in gene therapy clinical trials, in phase 3 trials I'm talking about.
Thank you.
So thank you, Mr. Mahoney. There are still uncertainties, but once these are cleared off, I think the gene therapy will be the best option for the treatment of hemophilia, despite its high cost. And it requires close collaborations of each type of stakeholders to get over these challenges. And I thank you very much for your contribution to our Congress, Mr. Mahoney.
Thank you.
Evet. Oturumumuz burada sonlanmıştır. Teşekkür ederiz.
Teşekkür ederiz.